And we're going to talk about diseases of the aorta and great vessels first. And we'll have Dr. Bowen come up here in just a moment after we go through his initial questions. So the first one is a 20-year-old woman who has MFS type B dissection and thoracoabdominal aneurysm repair. The mother's brother died at age 28 from an aortic dissection. The patient is asymptomatic. In September of 2016, the aortic group measured 43. In March of 2017, the aortic group now measures 46. It looks like this. What is the next step in management for this patient? Referral for preventative aortic repair, closer follow-up, doing the echo every 3 months, add beta blocker and losartan, or do cerebrovascular imaging to complete the workup. All right. The next question is a 55-year-old man with long-standing severe hypertension. He has acute chest pain, stable vital signs and laboratory findings, unremarkable EKG and chest x-ray. Troponins are negative, but the D dimer is positive. So a CTA was done for pulmonary embolism evaluation. Looks like this. What would you do? Anticoagulate for PE? Order a CTA for better images of the aorta? Order markers of inflammation and a temporal artery biopsy? Or refer for an aortic stent graft? Opportunities for education, Juan. Okay, a 75-year-old woman is asymptomatic, has a past history of polymyalgia rheumatica, and an incidental finding of a thoracoabdominal aneurysm. This is what it looks like. Which is correct? Without cranial symptoms, aortitis is unlikely. 2, a TE is the most sensitive test for aortitis. 3, she is a woman, so is very unlikely to have aortitis. Or 4, giant cell arteritis aortitis should be in the differential diagnosis. Well, we don't know whether you're right yet or not. I mean, come on. He hasn't even given you the lecture yet. We'll have to wait and see. All right. So Dr. Juan Bowen is the director of what used to be known as the Marfan Clinic, but now is really the complex and inherited thoracic aortic clinic, where they deal with all of these kinds of issues. And Juan is back to let us know if you were right or not. Juan, thanks for being here.
Thank you. Can you hear me okay? Yeah, and our clinic keeps getting more complex all the time. So here are our learning objectives, and we're going to talk about what causes aortic aneurysms and how do you manage them. What about the acute aortic syndromes, and what about the vasculitic disorders that can affect the aorta? So with number 1, when you're faced with the patient with thoracic aortic aneurysm, how do you figure out what the etiology is, and how do you make a management plan? So a good place to start is to really think about what's in the aorta. And the aorta, like all arteries, has 3 layers. And the most important layer is the media. And inside the aortic media, there is an extracellular matrix, which is very active metabolically, a lot of metabolic activity. It contains structural proteins like collagen. There are destructive enzymes, matrix metalloproteinases. And also, there are signaling pathways, most notably the TGF-beta pathway. There are also aortic smooth muscle cells, and these have contractile proteins. This whole business connects through these very fine connections to the elastic fiber network. Now remember that the proximal aorta is rich in elastic fibers. It has about 50 concentric elastic lamellae that give the aorta its mechanical properties of storing and releasing energy. And that elastic fiber network is critical for the function of the aorta. So once you understand that, then you can begin to understand how an aneurysm can form. And so let's take a look again. Here's our elastic fiber network at the bottom. So if you have a bad structural protein, like a collagen mutation, you might have a weak aortic wall. Also, let's say that a patient has very severe hypertension over many years. That could produce vascular wall stress, which would also damage the elastic fiber network. If the signaling pathways are malfunctioning, that can activate inflammatory and fibrotic pathways inside the cell that are destructive, and so can inflammation. So all of these can result in an overload of that finely tuned system. That results in elastin fragmentation. And that weakens the aorta, and the result of that is an aortic aneurysm. Now here is something you've seen before. This is an elastic fiber stain, and this is elastin fragmentation with the final common pathway of a lot of the diseases we're going to talk about. And this is what it's supposed to look like in the normal state. Now, so now you're with the patient, and how do you figure out what they have, knowing that? Well, if the patient is older and has vascular risk factors, a lot of times they're going to be in this category here, and they're not going to be in an inherited category like we see over here. Some of those older people will have giant cell arteritis, and that's the predominant inflammatory disorder you're going to see as adult cardiologists. You have to know how to recognize the aortic aneurysm syndromes, also to be aware that there are people who have completely normal phenotypes and yet have aortic aneurysm as an inherited problem. And then there's that big group of bicuspid aortic valve, which is 1% of the population. So the way you make the diagnosis is you take a personal history and a careful family history. You look at the physical examination in a little bit different way than you traditionally do, because you're looking for some dysmorphic features that are going to identify the syndromes. You will use imaging, as you already know how to use. And genetic testing is now more prominent than it used to be. It's lower in cost and it's better. And with all that, you get the diagnosis, and this allows you to determine prognosis and also to construct a management plan, because these patients are going to have this for life, so the management plan has to be lifelong. The imaging that we use is important for all of these: diagnosis, monitoring, identifying family members, so it's critical. And in our clinic, we use multimodality imaging. We don't just trust the echocardiogram. Here's an example why. Here's a patient who had a 40 millimeter aortic root, and on cross-sectional imaging, this was actually an eccentric root, and the greatest dimension was 48 millimeters. So if we find that it's a very symmetric root, we may follow that patient with echocardiography, but the initial visit, they get cross-sectional imaging with CTA or MRA. The genetic testing is really great these days, and when I get a positive result, it really gives me a very satisfying feeling because I get an answer. But if I get a negative result, the feeling is maybe a little less satisfying. And sometimes you get a variant of unknown significance where there's an alteration in the DNA, but the report says that, we don't really know what this means. And when this happens, I get this feeling like I'm sort of in purgatory. And so that's not quite as satisfying. Now, the mutations that cause aortopathy are in these four groups. They're signaling pathway, especially TGF-beta with a number of proteins, extracellular matrix proteins, and you'll notice that fibrillin-1 is in both of these categories because not only is it a structural protein, but it's also a big regulator of TGF-beta. This is an important one that we'll talk about. And then the contractile proteins, actin and myosin, have mutations. And then there are other ones. Notch1 is a developmental pathway that can go wrong and cause aortopathy. Now, going back, let's take a little more closer look at the TGF-beta pathway. This is the one in the Marfan syndrome and in other disorders. So it starts up here with the fibrillin molecule. And the fibrillin molecule keeps TGF-beta signaling in check and under control. The TGF-beta molecule then goes and connects to the receptor. There are two receptors, And then there is intracellular signaling and phosphorylation of the SMAD proteins. And these are the ones that then go on and activate programs in the nucleus that can be destructive. The same thing can happen through the AT1 receptor, also phosphorylating SMAD proteins and giving you the same result. The Marfan syndrome is diagnosed by recognizing the phenotype. That high TGF-beta signaling causes long bone overgrowth and other consequences, usually severe kyphoscoliosis. Patients are usually quite nearsighted and even have ectopia lentis. On the imaging, there are non-cardiovascular imaging features as well as cardiovascular imaging features. And the whole package is put together by recognizing the history, the exam findings, the imaging findings, and getting a genetic testing which identifies the causative mutation. This is a wonderful website that tells you everything you need to know. This is 1 in 5,000 people. And here's where the defect is. It's defective fibrillin, doesn't do the job of keeping TGF-beta signaling in check. The facial features, there are 5 of them. This is a famous actor who unfortunately died of this disease, and he's got all 5. He has a long face, dolichocephalic. He has deep-seated eyes because of decreased orbital fat. The medial canthus is higher than the lateral canthus. He has, this is a little subjective, but he has kind of an underdeveloped mid-face, and he also has, the mandible is also underdeveloped, so he has retrognathia. He's got all 5 of the features. In the skin, you look for striae, which is usually many more striae than you would normally see in anybody. And again, the high TGF-beta signaling with the long digits in the wrist and thumb sign. The patients will typically also, partly because of long bone overgrowth affecting the ribs, they'll get a pectus, either carinatum or excavatum. This is one of our patients where you can see the long limbs. They will have skeletal features that are usually pretty severe. A lot of people have scoliosis, but these patients tend to have severe kyphoscoliosis. They will get dural ectasia, which is not a specific finding, but is commonly seen in Marfan syndrome. And here's dural ectasia again. The eye in the Marfan syndrome, you may have a patient who has such an obvious lens dislocation that you can see it without any instruments, but if it's subtle, you need an eye doctor. This is an example. This finding is called iridodenesis. And if a patient has this kind of movement to the iris and hasn't had cataract surgery, that means that their lens has really fallen out of place. This is a highly specific finding for the Marfan syndrome because the zonules that hold the lens in place are made of fibrillin. So this means you have a fibrillinopathy. And this would be the characteristic vascular pattern in the Marfan syndrome. Not that they can't have aneurysms elsewhere, but usually the most affected area is the aortic root, and sometimes they don't have anything else, and sometimes they do, but it's usually here is where they're most affected. And to make the diagnosis, you use a score system, which you really can't remember, so I just go to the Marfan website. I also have, there's a smartphone application. If there is a family history, here are the criteria, the ectopia lentis, aortic dilatation. We use the Z-score. And when I look at an echocardiogram, they don't have Z-scores, as far as I know, for the mid-ascending aorta, but they do for the aortic root, and I just use the Z-score calculator that's on the Marfan website. When there's no family history, then you have to have, again, a dilated aorta, and then some of these systemic features, and also genetic testing. So there are different criteria depending on whether there's family history or not. A quarter of the patients do not have a family history because there are new mutations. A related syndrome, which was only described in 2005, is the Loeys-Dietz syndrome. These are Marfanoid patients, but they have a slightly different phenotype. Most of them will have widely spaced eyes and a bifid uvula. And on imaging, they're a little different. They have more aneurysms than in the Marfan syndrome, and they really prominent arterial tortuosity. The diagnosis, again, is by recognizing all this. And this is a TGF-beta problem that either at the receptor level or in those intermediary SMAD proteins. There are 4 of these Loeys-Dietz syndromes. And again, so the Marfan people are affected up here. The Loeys-Dietz people are here and down here, too. This is a Loeys-Dietz patient with a widely spaced eye. This is Dr. Loeys and Dr. Dietz when they were here in Rochester a year ago. And this would be the appearance of the uvula. You have to be a little careful because I think it's 1% of normal people have this. And I called one of our ENT surgeons one day and asked him what he thinks of when he sees a bifid uvula. He said, nothing. You know, you'll see that all the time. So for me, it was, oh, Loeys-Dietz syndrome. So this would be the arterial pattern that they have. This would be normal, and this is the tortuosity that's so prominent. And they'll have aneurysms in slightly different locations than the usual Marfan patient. This, for example, is a Loeys-Dietz patient, and there is root involvement here, but there's also involvement at the iliac artery level, and a little more tortuosity than you would expect in somebody in her 40s. This again is what you typically see with this level of tortuosity is unusual. Another syndrome is the vascular Ehlers-Danlos syndrome. This is really an important one. It's under-recognized. The patients may have a completely normal phenotype, but they often have a sort of a delicate appearance, and they'll have a thin skin. They tend to have either aneurysms or arterial ectasia, often don't have bad aneurysms. And it's an autosomal dominant disorder as well, but there can also be a new mutation. And this is how you diagnose it with the genetic testing, identifying that their vascular collagen has a mutation in it. And this is a patient who was in her 30s. This is another lady who's 25, and she's got this very thin, translucent skin. Both of them are sort of very delicate-looking people. And these are atrophic scars. All of us scar up our shins when we're children, but these people have these really atrophic-appearing scars. The first patient had this event at age 33, ruptured a hepatic artery aneurysm at 41, developed carotid cavernous sinus fistulas at 46, which somehow resolved. I don't know how they resolved, but they just cleared up. And unfortunately died at age 50 of a dissection that involved a non-dilated celiac axis. So very difficult to predict what's going to happen with this patient group, but it's a bad family history. So sometimes the aneurysms aren't that bad. And this is a Mayo study with 31 patients, and these are the locations, sort of a composite of where aneurysms existed in all those patients. It does matter what the mutation is. There's a milder haploinsufficiency mutation, which is milder, and the patients who have this can tolerate surgery. I have one who had a spontaneous coronary artery dissection, needed bypass surgery, and survived it fine. But if they have the really severe mutations, they have extremely high mortality from anything involving surgery or interventions on the vascular system. The final one we'll discuss is the Turner syndrome, which is familiar to you with a distinctive phenotype and aortic disease. And of course, this is an exokaryotype. Now, most of the time, this diagnosis will be made in infancy. These are the dilated lymphatics occurring, causing the webbed neck. It's not a rare condition, and lots of cardiovascular disease, not only left-sided defects, but as they grow up, they have to be watched because they have high conventional cardiovascular risk factors, hyperlipidemia, hypertension. The diagnosis is usually made in early life, but it can be missed and it can sometimes be made. I know Dr. Connolly recently had a patient in the hospital service who was in her 50s, and the hospital team connected the dots and figured out what was going on, but somehow this lady made it into her 50s without a diagnosis. This is a syndrome where the patient has a normal phenotype, and you're very familiar with this, 1% of the population. Dr. Michelena is one of our cardiologists who has studied this very closely. The ascending aorta is involved. Half of the patients have aneurysm. It's usually not the root, but it can be the root. This, of course, would be the appearance of the valve. And the main thing to remember is this isn't a valve problem, it's a proximal aortic problem. And the components are the valve anomaly, the aortic aneurysm, and in 15% of the patients, coarctation. And this is the natural history study that Dr. Michelena published, showing that these patients do develop the thoracic aortic aneurysms, but they have a low dissection risk relative to some of these other conditions, lower risk than the Marfan syndrome, but still 8-fold the dissection risk in the general population. The familial people can be hard to figure out because they have a totally normal phenotype. They do have thoracic aortic aneurysms, usually an autosomal dominant inheritance pattern. And when you do genetic testing with the panels that we use, which have about 20 tests, you'll only get a definite genetic diagnosis maybe 15 or 20% of the time in these people. In this one series, one of the actin mutations was the more common one, but in other series this hasn't been true, it's mixed. So these are our etiologies, and the sporadic people, the ones I mentioned at first, so when you see that older person, most of the time you don't have to go through all this genetic evaluation. They're not going to have it. It's going to be more in this category of decades of hypertension, smoking, etc. But some of them will have giant cell arteritis. This is an example of a typical older person where it probably is a sporadic situation. The inflammatory ones, I'll say a little more about these, but they can be diagnosed on imaging and laboratory testing, and we'll see a little more later. In our own clinic in the last 6 years, this is the breakdown of our patient population. About half of our patients have Marfan syndrome, but it has gotten complicated. We do have Loeys-Dietz patients, we have giant cell patients, we have a variety of the other mutations, we have bicuspid valve, so it's a mixed group of people. How do you manage this? The first thing you do is you protect the aorta. The radiologist made me a nice 3D model of one of our Marfan patients' aortas from the CTA. This is my Honda. And the patients have to have the understanding that they can't live their life the same way they always have. They have to change some behaviors in terms of avoiding extreme exertion, et cetera, contact sports. The medications, there are medications that have been tried at least in the Marfan syndrome that do seem to work, but medication like beta blockade or losartan will not keep anybody out of the operating room, but we hope will delay the need for the operating room. And in order to understand the treatments, you have to consider that the old model of this disease was that they had a weak protein, so they were destined to have tissue failure. But with the new optimistic model, now that the TGF-beta story has been told, this is potentially modifiable. And I think a lot of you are aware that this has been tried in mice. This is a normal mouse with normal aorta and normal aortic wall down here. And this is the Marfan mouse treated with placebo with aorta not looking very good. With propranolol, marginally better, not that much better, but with losartan, it really kind of normalizes the development of the mouse. The mouse never develops the Marfan phenotype. So naturally, this led to human trials. There was just a meta-analysis of 6 trials, and the basic message is that beta blockers and losartan do slow the rate of growth of the aorta in the Marfan syndrome. The effect so far is modest, and I can talk about this for a long time, but I won't. If any of you are curious later, we can talk about it. But it's basically does work, but it's modest so far. In terms of the guidelines, now you need to know for your examination that if it's a genetic mechanism, you have the choice of somewhere in this range referring the patient for preventive aortic repair. If it's an acquired mechanism, that's a little bigger. And if it's a bicuspid aortic valve, they can go to 55, but you have to think about the valve and its status. So there was a statement regarding these patients. And so, if you have other things going on, repair at 5 centimeters is reasonable. In the Marfan syndrome, we would usually be in this category here, but considering rapid growth or maybe a bad family history, you would send them a little sooner. The traditional operations, the Bentall operation that you're familiar with, composite graft, the valve-sparing operation has now been done about 20 years. It's a very good operation. It's very surgeon-dependent, of course, but it's so far as passing the test of time. So these disorders are complicated. They require very careful diagnosis and lots of care throughout the life of the patient. The patient's going to have this problem their whole life. So we're going to shift gears and go to learning objective number 2. We're going to talk about 3 conditions: aortic dissection, intramural hematoma, penetrating aortic ulcer. And in aortic dissection, even in this institution, diagnosis of, there was a publication in the 1990s where even at Mayo the correct diagnosis initially was made in fewer than half the patients. And it's because it's an uncommon problem, and you have to really suspect the diagnosis. You have to take a careful history and the right kind of examination and get on with imaging pretty quickly. The symptoms in IRAD, an international registry, 80% of the patients had pain, but they didn't all have pain. 20% had syncope for a variety of mechanisms, but notably usually tamponade. And you can see why the diagnosis can be difficult, because some present with heart failure or malperfusion symptoms. Then also, to make it a little tougher, again from IRAD, the mean aortic diameter with dissection was 5.3. So they can be not that dilated and present with dissection. If you could have your choice, this would be your preferred echo modality. It's just a little better than TTE, but TTE works very well too. So TTE is usually more available. It works fine. What about cross-sectional imaging? Cross-sectional imaging is actually the most common test that was used in the IRAD studies, and most of them got CTA as the first test. It's usually available in any emergency room. MR, not usually used for the initial diagnosis, but it is very helpful for follow-up. And it can be a little confusing, which test are you going to choose? And basically, it's whichever one you have at hand. So if you have echo right there, then use echo. If you have CTA, then use CTA. Once you have your diagnosis, then the classification is important because it's going to tell you a lot about prognosis and treatment. And there are two classification systems. And the DeBakey system was one which is used a little bit less, but it is still used with a type 1 dissection or a type 2 dissection. And then the type 3 dissection in the DeBakey system is the distal one. And the system that most people use today would be the Stanford system, which is A and B, proximal and distal. It's a little simpler. Once you have your diagnosis, you have, again from IRAD, now we have really good information about the natural history, and we recognize that there are several phases in acute dissection, and they're all bad. If you look at the graph, the hyperacute phase is the first 24 hours, but there's a really bad mortality with type A, and 84% of these patients were operated, and the type B do a little better, but there's continued risk even after the first month. Treatment would be, as soon as you suspect a diagnosis, provide adequate analgesic, and the most important thing is to control blood pressure and to be really aware for complications, tamponade, malperfusion, things that are going to require intervention. The type A's go for emergency surgery. When your patient survives, there are now more papers about this, the quality of life, what to tell people about exercise, but recognizing that they have an abnormal aorta that they're going to have the rest of their life, and they're going to need lifelong follow-up. So that's part of our job. We're going to control their blood pressure, and we're going to be monitoring with imaging, and we're going to send patients for surgery when there are complications, which there frequently are. The second emergency is intramural hematoma. An intramural hematoma is like this. It does not involve the intima. This is the wall of the aorta. In an intramural hematoma, what happens is that in the aortic media, where you have the vasa vasorum, there is a hemorrhage that starts somehow in the vasa vasorum, and it can be pretty extensive and produce this crescentic appearance. And you'll see that on imaging. This is an echo image where you'll clearly see that, and you'll see it on cross-sectional image. This tends to occur in older people. They usually are hypertensive, and the natural history parallels that of acute aortic dissection. Proximal disease is more dangerous. And I'm sorry to say that I had a 74-year-old hypertensive lady die of this just last week. So this does happen, and that's who tends to get it. The same patient population tends to get this problem, and when patients have aortic pain, this is the third emergency to think about. And the penetrating ulcer is a complication of atherosclerosis, and it's found usually in the descending aorta. As long as it doesn't involve the lumen, you don't get those bad things that you get with dissection. And it's diagnosed with imaging. Now, this is a little cartoon that shows you the walls, the layers of the aorta. So this is the adventitia, and this is the media, and then finally the intima with a plaque. Now a plaque can become ulcerated, and when that ulceration is just shallow, you don't have a problem, you don't have aortic pain. But as it gets a little deeper, then you can begin to get into a situation where you've got hemorrhage, and it can turn into an intramural hematoma. You can get a pseudoaneurysm or even frank rupture. And as you get out to where the pain fibers are, then you develop aortic pain. So this, you can see the possibility of both intramural hematoma and aortic ulcer turning into dissection. So this is one of the features of these emergencies. The management is usually medical, but again, because of the dynamic and changing nature of these conditions, patients have to be watched for complications, and some will require interventions. So the summary would be these are not very common, but they're lethal. You have to know that there are 3 of these conditions. You have to know how they present and really jump on the diagnosis with the tools you have at hand. I'm going to finish up with the vasculitic disorders. There are a lot of these, but really for our purposes as adult doctors, it's going to be giant cell arteritis. And this is the most common large vessel vasculitis in the elderly. In the younger person, think of the Takayasu arteritis, which is a little different natural history. The older people can have a clinical spectrum where they're kind of pretty cranial or really more aortic. And the aortic presentation can be inflammatory or can be stenotic. And the importance of this is reflected in the revised criteria. They revise these every few years, but now the criteria do include evidence of large vessel vasculitis. In our own institution, we recently looked at the patients that had giant cell, proven giant cell, and how many of them had an aortic abnormality. And it was basically about half of them. And it ranged all the way from aneurysm to dissection in a very small group here, 4%. And it's recognized on imaging with thickening here. And here's a normal segment, but here's a thickened aortic segment. This is a patient that came for an appointment with no symptoms of giant cell, but said, "Why is my left hand always cold?" And she had a tapered segment in her upper extremities. This is not atherosclerosis, this is arteritic narrowing. She had giant cell arteritis. And really, when you take people with cranial presentations, if you scan them with a PET scan, half of them have aortitis. And again, here's the path that you've seen before with the giant cells causing this inflammatory disease. Now, if you take, it's kind of interesting, so who gets an aneurysm and how long does it take? One of the rheumatologists, there's several rheumatologists at Mayo did ask that question, and they followed a group of people with a giant cell arteritis. So on the horizontal axis is the disease duration, and then the rate of aortic complications is up here. And you can see that some patients had aortic aneurysm at the beginning of the disease, but their disease was treated and was quiescent, but then there was a risk of eventually developing aortic aneurysm, again because that elastic fiber network has been damaged and the aorta is weak. It's now known that at least in many patients, maybe this isn't conclusive for all of them, but IL-6 is the mediator that seems to trigger the inflammation. And you're now seeing trials of antibodies that are anti-IL-6 agents that are being used in giant cell arteritis with great promise. So we may be in an era of decreasing the morbidity of long-term prednisone use and using a more targeted therapy. So for your boards, just remember that it's when young patients are the ones who are likely to have the genetically mediated problems that they go to surgery sooner than the older people. Be aware of the 3 aortic syndromes and know the basics. Know that they can kind of morph into dissection. And be aware that the most common form of vasculitis in the elderly is giant cell. Some nice, useful articles, and this is one of our rheumatologists who recently published a nice paper on giant cell arteritis. So with that, I want to thank you very much. And
Come join me over here.
oh, I get to sit down.
You get to sit down now and relax. All right, so back to our 3 cases. The first one is a 21-year-old woman whose mother had Marfan syndrome with a type B dissection and a thoracoabdominal aneurysm repair. The mother's brother died at age 28 of an aortic dissection. This patient is asymptomatic, but in September of last year, her aortic root was 43, and a handful of months later, it was 46. And so the question is going to be, the image next, this is what it looks like. And then the question we're going to ask you is, what's the next step in the management of this patient? Is it referral for preventive aortic repair? Is it closer follow-up, like every 3 months? Is it continuing combining beta blocker and losartan? or is it doing cerebrovascular imaging to complete the workup? Which is the best answer? So 79% said they're going to refer them to repair. Juan, you want to make some comments?
Yes, this is an example of, we really had a close call here. This young lady had this very adverse family history and went in September for her usual echo, and the surgeon wanted a CTA, and we ordered it, but she didn't show for it, and basically we couldn't find her for a number of months. Her attitude was, what could possibly go wrong? Then when we found her and got the CTA, we were shocked that her aorta not only had increased in size over the intervening 6 months, but that little bulge, I don't know if you can go back to the image, there was a little localized bulge on that aorta that was actually, when the surgeon operated, there was a small intimal tear on the inside of that localized bulge. So this was a dissection about to happen, and just an example of how high risk these patients can be. So when they're in that 40 to 50 range and they have adverse family history and other features that are looking bad, just get them into the operating room promptly.
Do you then start them on the beta blocker and losartan after you've done the aortic repair?
At diagnosis. So
so let's say this woman hadn't been on it so far and she gets to this point, then you repaired the acute aneurysm, but the rest of the aorta is still...
Yes, unfortunately, these patients have a lifelong 10% risk of descending dissection, and unfortunately, it sounds like we're having dissections all the time, but just last week, one of our Marfan patients who had a previous aortic root repair dissected a non-dilated descending aorta, and they do this. So the aorta is diseased, and especially in the Dutch losartan trial, treatment with medication in postoperative adult patients did reduce the rate of growth.
Okay. And then one practical question has to do with adjusting the size of the aorta for the size of the human being you're looking at. So some of these patients are tall people, but then we have, NBA players, how do you adjust for the fact that some people are just bigger than others and yet we're using static
Yes, that's a very good point. And the person who's probably thought about this more than anybody is Dick Devereaux at Cornell. And he's the one he and Mary Roman are the ones who established the Z-scores for the root. But in Dr. Devereaux's opinion, no human being should ever have an aortic root greater than 43, no matter how big they are. And but also where this really comes up is in those Turner patients who have short stature. There are alternate ways that are corrected for body surface area that are not the same Z-score. So you can have some discussion about those short stature people, and there's not a definite gold standard. But at least in the Marfan population, that 40 to 50 recommendation has really served us well.
All right, we'll go on to the next question. It's a 55-year-old man and with long-standing severe hypertension. He's got acute chest pain, stable vital signs and laboratory findings. He has an unremarkable ECG and chest X-ray. Let me see. We get a CT scan that looks like that. Look at it for a moment. Take it all in. And as you're looking at this, I'll read you the questions that you're considering. Are you going to anticoagulate this person because of a PE? Are you going to order a CTA specifically for better images of the aorta? Are you going to order biomarkers of inflammation and temporal artery biopsy? Or are you going to refer for an aortic stent graft? Okay. So vote on that now. So 52% said get a CTA of the aorta, 31% said refer for stent graft.
Yeah, this is a regular hypertensive patient. He's not in our aortopathy practice, and he was out of town, got chest pain, came to see me 2 weeks later, and he said, good news, I didn't have a pulmonary embolus. But, you get the images when people have events like this. So I requested the images came back, and, what's that? You can tell he doesn't have a PE, but his aorta doesn't look normal. So I did get a CTA, and what he really had was a penetrating aortic ulcer, which had penetrated through and into the intima and given him an aortic dissection that was all up and down the aorta. And so it was visible right there on those PE study images, but the radiologists were so focused on the PE that they ignored the aorta.
All right. The next question is a 75-year-old woman who's asymptomatic, past history of polymyalgia rheumatica, an incidental finding of a thoracoabdominal aneurysm or a thoracic aortic aneurysm. And it looks like this on the screen. It looks like it needs a seatbelt in the back of a Honda. And as you're looking at that aorta, I'm going to ask you which is correct about this. Without cranial symptoms, aortitis is very unlikely. A transesophageal echocardiogram would be the most sensitive test for aortitis. She's a woman, so it's not likely to be aortitis. Or GCA should be in the differential diagnosis. Ooh, 99%. Wait, are they right?
Well, I think I have to get better at wording these questions, because anytime you say should be in the differential diagnosis. Sure. Yeah, and I think the point here is that, well, there was a little clue there that she's had polymyalgia rheumatica, but never had cranial symptoms. And in our practice, we send elderly patients for repair of aneurysms with absolutely no indication that they ever had aortitis, and yet the pathology comes back, giant cell arteritis in a small percent. So this is, I think, unrecognized situation. But now you know it can be asymptomatic, they can have inflammatory symptoms, or they can have stenotic symptoms.
So do you need a temporal artery biopsy?
It's often negative. It's a different disease. Some of these patients have preferential involvement of the aorta and without cranial involvement, and they can even involve, which was news to me, but reading about this, they can even involve the entire aorta down to the iliacs in its giant cell pathology.
There was a few questions that came in, particularly when you're talking about your patients with the various aortopathies. And maybe they have a bicuspid valve, but now that we have all these transcatheter valve therapies, but yet you might have patients who have these aortopathies, how are those going to intersect with each other, you think? Are those patients going to be eligible for or not eligible for transcatheter valve and aortic stent grafts, et cetera?
Well, technology is rapidly evolving, and there are nuances to this that you have to look at individual cases, but the big message would be that the people who benefit from transcatheter stent grafting are the older people with hard aortas where there's a good landing zone and it's okay to exert radial force on that aorta. And in our young genetic aortopathy patients, it's a bad thing to have soft aortas, they don't have a good landing zone, it's not good to exert radial force on a soft aorta. So that would be the general answer. Now, we have had stent grafting done in our Marfan population in very specific situations. I know one of our surgeons operated on an emergency case a couple of years ago, and it was a matter of somehow getting the patient out of the operating room alive. So he did use a stent graft just to buy time, but then brought the patient back a few weeks later and did an open repair.
And a bicuspid aortic valve, now right now a lot of those are excluded from some of the transcatheter valves, but given the associated aortopathy, would you be interested or scared about sending someone for a balloon-deployed valve in someone who has a potential aortopathy?
I'm not sure how much this has been studied yet, but the bicuspid people are very interesting. And Dr. Michelena wrote a beautiful paper about this a couple of years ago, where he called the bicuspid aortic valve problem a victim of parsimony. But he talks like that. But what he means, though, is that this is a complicated situation. You really have to look at these individuals as individual cases, because there's an aortopathy that's inherent in the disease, but there's also a hemodynamic effect of the jet from the stenotic valve hitting the wall of the aorta and producing an eccentric bulge there. So it's really two things. So I think I would be nervous about any kind of endovascular approach given that.
And another question on the bicuspid aortic valve patients. So you know, the classic teaching has been you screen their family with an echo, and if it's doesn't have two cusps, then you're okay. But again, would you screen further on throughout life just because of the possibility of coexistent aortopathy?
This is a little unresolved. What you really love to have is a biomarker. So in some of the other genetic aortopathies, we do have those biomarkers. So when you do find that affected person, you don't have to do all this echo checking forever on family members. You can just, do they have or not the marker? Unfortunately, there's no marker in the bicuspid valve disease. And it is possible for a sibling, for example, to have the aortic anomaly without the valve anomaly. So unfortunately, if you're really going to be a purist and do it exactly right, you do follow the first-degree relatives. Now, in practice, that's very hard to do. You can't get insurance companies to do it, and you can't get patients to do it. But that would be the very best thing to do.